This slide details the unique characteristics of the 7 cell types that make up a CBC, that is, a complete blood count. These are the cells that we will be analyzing for the remainder of this session. In making the assessment of the CBC and differential, the hemogram is a collection of 7 tests, of which 3 are calculated from the first 4 and make up the complete blood count. The white blood cell count, or WBC, reveals the body's capability of responding to an immunological challenge and its ability to mount an assault on an infection. The primary organs involved are the bone marrow and thymus gland. Unfavorable signs on a white blood count and differential seen during an infection are extreme leukocytosis with a high percentage of neutrophils, a failure to develop leukocytosis, a presence of a high proportion of immature cells, the appearance of numerous toxic cell forms, and last, a marked absolute reduction in the lymphocyte population. As the patient responds to therapy, the blood picture during recovery exhibits a decrease in total leukocyte count and neutrophils. There is a decrease of immature forms, a temporary increase of monocytes, and the appearance of eosinophils, plus an increase in the lymphocyte population and the absence or decrease of toxic cell forms. Pathologically increased total white count values are seen in leukemia, infections, and leukemoid reactions. A decreased total white count value less than 4.0 are observed in bone marrow depression, in the later stages of HIV infection, in other words AIDS, and in leukemic leukemia. Acute infections should be considered when the white count exceeds 10,000 cells, and the polymorphonuclears, or SEGs, are greater than 75%, and the population of lymphocytes are less than 20% on the differential. Chronic infections typically will show a white count above 8,500, and the segmented neutrophils and lymphocytes appear essentially normal on the differential. Nutritional and functional bone marrow depression is common and often missed by most physicians. The depression on the lab test of those cells that are created by the stem cell in the bone marrow indicate that their populations are not being adequately manufactured. The key to identification is to look for these lower than normal populations and commence treatment with folic acid and vitamin B12. This slide displays the rule for distinguishing bone marrow depression. Note that any 2 values are indicative of a depressed bone marrow. First, a white count less than 5, then a red count less than 4.5, or a differential neutrophil count less than 55%, or a mean corpuscular volume of red cells greater than 97%, and last, a platelet population less than 140,000. Now there is an exception to this rule. If the white count is less than 3.6, and there is no additional factor below normal, as mentioned, then consider this early marrow depression and commence folic acid and vitamin B12 therapy immediately. An elevated white count means one of 2 things. There's an infection, or they have a myeloproliferative disorder, probably leukemia. Here's a pretty good rule of thumb. If the SEGs are high and the lymphs are low, the infection is acute. In a chronic infection, the SEGs and lymphs are essentially normal. Factually, there is only one reason why the white count drops, and that's bone marrow depression. This slide shows the therapeutic nutrition that may be necessary when the white blood count is elevated and when it is decreased. It is important to differentiate a functional thymus disorder from a metabolic food rejectivity or food allergy condition. When the thymus is not functioning up to par, there will be a deficiency in lymphocytes, usually less than 25%, and an elevation of segs greater than 70%, and there will be a normal white count. Whereas when the body is reacting to or rejecting some foods, look for a normal white count, a normal red count, a segmented neutrophil population less than 55%, lymphocytes that are usually elevated above 25%, and a monocyte colony greater than 8%. The appropriate nutrients are listed at the bottom of this slide. Red blood cell counts will reveal the oxygen-carrying ability of the blood. The primary organ involved is the spleen. A pathologically increased red blood count may be the result of dehydration, polycythemia vera, some chronic heart diseases, acute poisoning, pulmonary fibrosis, and a Yersin's disease. Depressed red counts are due to anemia, leukemia, and after hemorrhage when the blood volume has been restored. Abnormal shapes and sizes of the red blood cells are seen in anemia and some myeloproliferative disorders. The red cell morphology as seen here shows a normal red cell that appears essentially round with all of the cells about the same size. In poikilocytosis, the cells are oblong or pointed, and they vary in size and shape. The cells in anisocytosis appear round with a marked variance in the size of the cells. Some can be quite large, and others very small. In acanthocytosis, although the red blood cells are round, they take on a burr-shaped appearance. The cells are round and very small in microcytosis, and of course, the cells are quite large in macrocytosis. This slide and the following slide image shows the microscopic appearance of red cells in various disorders. Note how some cells lacking iron are very pale and others are quite dark. Certainly, some of the cell shapes can be very, very bizarre. Nutritional therapy indicated for an elevated red blood count would include spleen glandular, beta-carotene, vitamin E, and sometimes copper. Therapeutic nutrition for a low red count would include folic acid, vitamin B12, copper, and pyridoxine, or B6. Influenced by the spleen and bone marrow, hemoglobin reveals the amount of intracellular iron in the red blood cells. Increased hemoglobin values are seen in dehydration and polycythemia, whereas pathologically decreased hemoglobin values occur in anemia. The hematocrit reveals the amount of red blood cell production, or cell volume, and is influenced by the spleen. It is pathologically increased in dehydration and polycythemia, and is depressed in anemia. For all practical purposes, the red blood count, hemoglobin, and hematocrit have the same related pathways, and are elevated by dehydration, polycythemia vera, chronic heart disease, and in a Yersin's disease. Of course, This pathway would be identified by the signs and symptoms of a Yers's disease, which are characterized by chronic cyanosis and dyspnea, chronic bronchitis, bronchiectasis, enlargement of the liver and spleen, and hyperplasia of the bone marrow. A low sodium and BUN creatine ratio would suggest dehydration due to relative polycythemia. There are several forms of polycythemia vera which would require a differential diagnosis, as it may be found in chronic splenomegalich disorders, hypertonic spleen, myelopathic and secondary polycythemia due to anemia. The red cell population will elevate in an effort to compensate for the oxygen deprivation in chronic heart disease. Decreased levels of the red blood count population, the hemoglobin, and the hematocrit presents with 5 areas of concern. The first is to rule out or establish a hypochromic anemia, which is characterized by a low serum ferritin. Although serum iron may be high or low, always order a serum ferritin to confirm the diagnosis. Next, is there an anemia resulting from a chronic disease? The serum ferritin will be elevated and there will be signs and symptoms of chronic disease. Third, check for an oligocythemic or normochromic normocytic anemia, which characteristically shows the red cells as normal, with exception that the numbers are less than normal. If the white count is increased, then leukemia must be ruled out by a bone marrow biopsy. And last, if the patient has experienced a recent massive loss of blood, certainly the red blood count, hemoglobin, and hematocrit will be decreased. Here is a useful table that demonstrates a detailed method of assessing iron deficiency, a need for vitamin B12 and folic acid, and a deficiency in vitamin B12, folic acid, and vitamin E. As in the previous slide, this table is beneficial in identifying vitamin B12 deficiencies and folic acid deficiency. You will note, I do not recommend a serum folate to assess folate levels. The reason being, a serum determination simply shows the level of folate in the plasma, rather than a more accurate demonstration of the biological activity of the cell populations by the bone marrow, as shown on this slide. The platelets, or thrombocytes, reveal the potential for blood coagulability as generated by the bone marrow. Pathologically increased platelet values are seen in myeloproliferative disorders and polycythemia vera. Pathologically decreased platelet values are seen in thrombocytopenia, in leukemia, and cirrhosis of the liver. Although the calculations of the MCH, the MCHC, and the MCV are usually made and provided to you by your reference laboratory, I have provided you with the formulas so you will be cognizant of how they are calculated. The mean corpuscular hemoglobin, or MCH, reveals the weight of the iron in the red cells. You can see the formula is the hemoglobin multiplied by 10 and then divided by the red blood cell count. The mean corpuscular hemoglobin concentration, or MCHC, reveals the concentration of iron in the red cells. The calculation is to multiply the hemoglobin by 100 and then divide this figure by the hematocrit. And last, the mean corpuscular volume, or MCV, indicates the size or maturity of the red blood cells. The formula is calculated by multiplying the hematocrit by 10 and then divide this by the red cell count. When the MCV is high, prescribe folic acid and vitamin B12. And when the MCV is low, give the patient iron and spleen glandular. Here are 8 miscellaneous considerations that may be of value when prescribing nutrient therapy. First, patients should not take vitamin E and iron at the same time of day, since vitamin E is an antioxidant and iron is an oxidant, and the two will compete biologically. Second, patients should limit their intake of tea, milk, eggs, or foods containing phytic acid, whole grains, and cereals when on iron therapy, as they can bind with the iron and make the nutrient insoluble. Patients with hemolytic anemia should be placed on vitamin E therapy, approximately 800 international units per day, as it can map up free radicals. Fourth, as mentioned earlier, patients with normochromic normocytic anemia should be placed on vitamin E therapy. This will protect the red blood cell phospholipid envelope from free radical damage. Fifth, iron is best absorbed on an empty stomach. Unless the patient complains of indigestion with the iron, have them take the iron between meals. Number 6. Folate deficiency is present in more than half of patients with megaloblastic anemia due to disease of the proximal ileum. These patients usually will show evidence of folic acid deficiency on the blood test. 7. Also, disease of the distal ileum may result in vitamin B12 deficiency that can be demonstrated on the CBC and differential panel, as described earlier. Allopathic physicians commonly prescribe potassium chloride for a potassium deficiency. Watch your patients closely for a vitamin B12 deficiency, as potassium chloride, KCl, can alter intestinal pH and interfere with vitamin B12 assimilation. When prescribing very high-dose proteolytic enzymes for several weeks at a time, the blood coagulation times should be monitored to prevent the blood from getting too thin, resulting in a high coagulation time. Neutrophils, also known as polymorphonuclear segmented neutrophilic leukocytes, comprise the first line of defense against bacterial infections. Neutrophils arise from the stem cells in the bone marrow. Band cells, also known as stab cells or C cells, are immature non-segmented neutrophilic cells. An increase of band cells indicates there is probably a latent infection developing. Segmented neutrophils are mature cells. The more lobulated their nucleus, the older the cell. These cells, when highly lobulated, that is, over 6 or 7 segments, are frequently seen in vitamin B12 and folate deficiencies. Of course, the neutrophils are under the influence of the bone marrow. Neutrophils increase in acute infections due to cocci. They often are quite elevated in pneumonia, scarlet fever, and meningitis. They also multiply with localized infections, producing an abundance of pus, especially when the lesion is under pressure. They increase in some general infections, such as rheumatic fever, diphtheria, and smallpox. Neutrophils respond immunologically in some metabolic disorders, such as uremia, diabetic acidosis, eclampsia, gout, and in poisoning by certain chemicals and drugs, when there is hemorrhage and an acute or sudden hemolysis of erythrocytes. In postoperative states, coronary thrombosis, and in some malignant neoplasms. Elevations can occur due to physiological mechanisms that may occur after strenuous exercise, during late pregnancy and labor, after repeated vomiting, convulsions, paroxysmal tachycardia, in the newborn, and in several moribund conditions as well. Pathologically decreased neutrophil values are seen when there is bone marrow depression and in the late stages of an HIV infection or AIDS. It's readily apparent that when neutrophils are elevated, an aggressive clinical investigation must be instituted to identify the source of the increased cells. Look for a local or systemic infection, malignant disease, and coronary thrombosis. Or perhaps they are increased as a result of a physiological cause, as seen after exercise, a late pregnancy, and other conditions. Of course, the presence of vomiting and a hemorrhagic condition is obvious. There is only one reason neutrophils are low, and that is bone marrow depression. Beta-carotene, thymus glandular, vitamin C, and garlic extract have proven beneficial when the neutrophils are high, and as mentioned before, vitamin B12 and folic acid are the nutrients of choice when the neutrophils are low. The lymphocytes and their subsets, the B and T cells, reveal cell-mediated immunity that is orchestrated by the thymus gland and bone marrow. Pathological elevations of lymphocytes are seen in the metabolic rejectivity syndrome or delayed reaction food allergies. Also in many acute and chronic infections, during the state of convalescence from an acute infection, in bacillary infections, exophthalmic goiter, and sometimes in bone marrow depression. Lymphocytes are found decreased in immunodeficiency disorders, viral infections, and especially HIV infections, or AIDS. Low values are normal in infants and young children. An elevated white count with a preponderance of lymphocytes suggests an acute, probably viral infection. A high lymphocyte count is seen in delayed food reactions, some chronic infections, bacillary infections, and as a normal finding in infants and young children. Low lymphocyte populations suggest a viral infection when the white count is elevated, and they also elevate in immunosuppressive disease. SAGE testing, or IgG, IgM, and IgA-RAS tests are useful when the lymphocytes are high. Often these patients respond positively when they are placed on a 4-day rotation diet. Thymus glandular, vitamin C, beta-carotene, zinc, and manganese are often indicated when the lymph population is low. Monocytes reflect phagocytic activity and are derived from the bone marrow. Monocytes often elevate in the presence of food allergies. Primarily concerned with phagocytic activity, the monocytes elevate in a host of diseases in pathological conditions, such as bacterial infections, during the recovery from acute infections, and protozoal infections, and amoebic dysentery. They also are increased in Hodgkin's disease, Gaucher's disease, carbon tetrachloride poisoning, during the recovery from agranulocytosis, and they may be an early sign of leukemia. Decreased monocytes have no clinical significance. However, it is well to mention that high doses of corticosteroid therapy will depress the monocyte population. Elevated monocytes, coupled with an increased white count, should direct your thoughts to either a protozoal or bacterial infection. Populations over 8% are often seen in patients with food allergies. There are several miscellaneous conditions associated with a high monocyte count. Low monocytes with an elevated white count may be seen in acute neutrophilic infections where there is a marked left shift in neutrophils. And as mentioned earlier, corticosteroids will depress the monocytes. Vitamin C, beta-carotene, thymus, and proteolytic enzymes may be beneficial for patients with increased monocytes. Eosinophils are a manifestation of IgE-mediated allergies. They are a reflection of gut allergies, aerobic membrane allergies, and the presence of gut parasites. Pathologically increased eosinophils are commonly seen in IgE-mediated allergies such as bronchial asthma, hay fever, urticaria, serum sickness, and angioneurotic edema. Skin diseases such as pemphigus, eczema, and dermatitis herpetiformis. It is also increased in parasitic disease such as trichinosis, echinoccal disease, schistosomiasis, infestation with liver flukes, and also some intestinal parasites. Specific infections such as scarlet fever, chorea, erythema multiforme, and chronic gonorrhea, blood dyscrasias like Hodgkin's disease after a splenectomy, and pernicious anemia, especially after raw liver therapy. Eosinophils often increase following radiation therapy. As a familial anomaly, accompanying tumors of the ovary or tumors involving serous surfaces of the bones, and after certain poisons. Eosinophils may be increased in patients with epilepsy. A low eosinophil value is not clinically significant. There are 7 pathways to consider with elevated eosinophils. First is IgE-mediated food allergies. Next, check for signs and symptoms of skin diseases, eczema, pemphigus, and others. Are there parasites? If the white count is increased, suspect an infection associated with eosinophilia. And last, is the patient an epileptic? Keep in mind there is no concern for a low eosinophil count. Basophils reveal the potential for cell-mediated histamine levels and associated toxic allergic states. A pathological increased basophil count may be seen in infections such as a chronic sinus inflammation, smallpox, and chickenpox. High levels attend various blood dyscrasias, sometimes in chronic hemolytic anemia, in chlorosis of the liver, and following splenectomy. It has been observed in Hodgkin's disease and following the injection of foreign protein. In an ideal test, there would be no basophils present. Basophilia, or elevated basophils, with an elevated white blood count, would suggest an infection associated with basophilia, like smallpox or chickenpox. Are there findings in the CBC suggestive of hemolytic anemia? Has the patient undergone a splenectomy? Are there clinical signs of a high-level histamine allergy? And finally, does the patient have evidence of Hodgkin's disease? And as we mentioned before, the absence of basophils in the blood test is a good thing to find. A patient who exhibits increased basophils on the blood test probably would benefit by taking cysteine, bioflavonoids, vitamin C, thymus glandular, and proteolytic enzymes, among other nutrients, of course. This session has provided you with a practical method of assessing the pathological, functional, and nutritional elements in human blood. Although there is a wealth of knowledge and much detail in these pages and slide images, you can easily learn by merely doing. For it is only by doing that we are able to develop a skillful and superb ability to read the telltale signs of the blood. It will be slow at first, but with perseverance you will find that speed will soon follow accuracy. In Session 1, we established the foundation and philosophical elements associated with the many benefits of performing routine and specialized blood panels. Now I urge you to begin ordering blood work on all of your new patients and the return of former patients. Even those patients who are presently under your care may exhibit signs and symptoms that warrant a blood assessment. After you have interpreted the blood tests, decide when you should do a second comparative test so you can make the appropriate changes in nutritional therapy. Usually a repeat panel is performed in 4 to 6 weeks, sooner if the test shows ominous signs. Give your patient a copy of the blood test and a list of the nutrients necessary to correct the abnormal findings. In our next session on blood, Session 7, we'll review the salient features of the multi-channel 24 thyroid panel and CBC with differential, and what you should commit to memory. In addition, we'll show you how to calculate nutrient dosages based on patient body weight and when the nutrients should be consumed, such as with meals, between meals, chewed, swallowed, whole, and so forth. Session 7 also introduces you to an additional blood chemistry test that will prove helpful when assessing the basic blood panels as set forth in this session. Should you have any questions or concerns about the material, I want to remind you of our internet chat room on Thursday evenings at 7 o'clock p.m. Mountain Standard Time. That would be 9 o'clock Eastern, 8 o'clock Central, and 6 o'clock on the West Coast. Simply log on to CessnaConsulting.com, typed all as one word in lowercase, and then click on Chat and follow the instructions. Of course, there is no charge. I promise you, once you have learned how valuable a well-interpreted blood test can be, you will never again practice without it. I look forward to our next session together. I thank you, and good luck.